Welcome to Advanced Patient Care, a podcast series by Vance Thompson Vision. Today's podcast features Retina Reflections, and I'm your host, Dr. Jed Assam. This podcast is here to bring you the latest advancements in cutting-edge research and practical tips that you can apply to your clinical practice right away. So if you're ready to expand your knowledge, stay ahead of the curve, and elevate your practice, you're in the right place. So one of the things that I wanted to chat about that's been a common theme of discussion recently in retina is what do you do about dry age-related macular degeneration? This is something that we've all dealt with, one of the most common things, especially in our Midwest environment where we find ourselves practicing. Over 80% of macular degeneration in general is in the dry form, and it's one of the leading causes of vision loss for our patients. So what do we do about it, and how do I tend to approach it in my practice when I see patients? And what are the options that you can talk to patients about that are available to them in the present age? One of the biggest things, and this has been an age-old thing for a very long time, is don't forget the importance of low vision therapy. And the way I often present it to patients is vision rehabilitation therapy, because it really kind of helps to introduce the idea that what we're trying to do for them is take an existing condition that is visually significant and at this time irreversible, and we're trying to give them a way to be able to continue to function in life around that and to be able to do things that they still like to do, but they just have to learn to adapt to it in a different way. I'm often surprised at how many times I do see people that haven't heard that this is an option available to them. I think a lot of people are concerned about bringing up the idea of low vision and bringing up that aspect that there is a likely projection going forward that the patient will continue to lose vision. But it's important to address this earlier, because the sooner that we can get these individuals to vision rehab and a low vision specialist into those resources, the more they're able to adapt, and more easily typically than when it's more significantly progressed. It's still a great thing at any point in time, but ultimately just want to make sure that it's an emphasis that people remember that this is a huge piece of helping these patients continue to live out their daily lives with a condition that is going to affect it going forward. The next options are ones that a lot of people have probably heard advertised, and those include a new injection series that's come out for dry macular degeneration. And the specific pathway that is being targeted, just in a review of that, is the complement pathway. And now, harkening back to biochemistry and science, and so this is a part of our immune system. We've got two different forms, our innate and our adaptive immune system. The adaptive, you might think of as white blood cells going in, targeting the cellular component of it that gets charged up to go take things out. But the innate immune system is our antibodies and the pathway that then eventually leads to the complement system pathway, where we get a series of reactions that develop to essentially introduce a MAC complex to remove the pathogen of interest. This pathway is important because in macular degeneration, there's kind of a three-fold process of reactive oxygen species involvement, inflammatory cascades, and then microvasculature, particularly choriocapillaris problems that begin to occur that at this time are believed to be all in some level contributing to the process of dry macular degeneration. And with these new therapies that have come out, what is being targeted is that second approach, the complement system, or the inflammation that's happening locally around specifically the photoreceptors, the retinal pigment epithelium, and the choriocapillaris. And those two medications are pegcetacoplan and avacincaptad-pegol, what we might know more so as Syfovre and Izervay from the marketing standpoint. Those are the two current medications. They've both been out at this point almost a year, and in one case over a year at this time. It's a interesting dialogue to bring up with patients because it's not quite the same at this time as the historic wet macular degeneration drugs. With these dry form of macular degeneration drugs, as we said at the very beginning of the podcast, there's still the presence of progression, even with the use of therapy. So dry macular degeneration still does not have a cure or something to completely stop it in its tracks. As a result, the conversation for these types of drugs, it's important to make sure that the patient understands when you're discussing the potential to either refer or provide a medication like this for them, that really what they have at the present time is the best that their vision is going to be going forward. And in fact, it will continue to get worse, even with the therapy, but it will get worse slower. The purpose of these drugs primarily is what we've been seeing over the last 3 years to provide a slowing of the progressive nature of dry macular degeneration, specifically the geographic atrophy component of dry macular degeneration. So when I'm talking to patients about this, biggest piece is understanding that we're balancing, essentially going from, the way I'll use is 100 miles an hour down to 75. We're still moving forward, but we're going to be moving forward slower to provide some vision for longer. And this is really kind of one of those things that as we're reducing this surface area of growth of these geographic atrophy lesions, what we're doing is we're reducing the rate that the scotoma is developing and the debilitating nature of the disease in different forms. The biggest question that then comes up and an important topic of conversation is, what are the side effects with these types of drugs? And between the two, it's important to make sure that you're talking about the potentials for standard risks of any injection, pain, bleeding, and infection. The other ones that are more typical, and kind of the big three that I always make sure to emphasize with patients, is one, we're in a state typically of dry macular degeneration when we begin talking about these drugs. And there is a noted increase in the percentage of patients over the studies that patients do become at higher risk for developing the wet form of macular degeneration. Almost 1 in 10 in many cases is roughly the percentage, but depending on the rate of delivery, the frequency of the medication, which was in the studies done monthly and every other month, most commonly in clinical practice today, people are doing every other month to gain the benefit of slowing things down while lowering that side effect profile to more of the 12% to 9% of cases where patients are developing that wet macular degeneration. But it is an important one to mention because that can mean needing to adjust therapy or give another injection to the patients beyond the dry macular degenerations. The other two are both conditions that can lead to blindness for the patient from the drug delivery. Fortunately, the risk of this happening is around 1 in 2,000 in both cases, but that is the way that I do mention it to patients, is they can be sight-threatening side effects, and those that were observed included non-arteritic anterior ischemic optic neuropathy, or NAION, as well as the presence of retinal vasculitis or vessel inflammation in the eye. And the impact of those in both cases can be very damaging. Those are 3 important things that are important to discuss with the patient about the side effect profiles when we're talking about this. The next step in the conversation beyond that is talking to them about the commitment to therapy. So this is like any other injection to the eye in the present era. It's for macular degeneration. It's something that's ongoing. And at this time, what's been observed is it's not something where we give a few injections and we maintain the effect of the injected drug for dry macular degeneration, meaning that we don't reduce the growth rate by that anywhere from 15 to 25% and maintain it if we stop the injections. And what's been actually observed is when injections are stopped, within 6 months, the rate of growth for the geographic atrophy returns to normal. So the patient is, when we're doing this, one, committing to an injection at least on an every 2-month basis, and they're doing it to help slow the rate of progression. And so this can become a factor for folks committing to an every 2-month proposition for therapy in something that is knowingly not going to improve their vision, but is going to help sustain aspects of it for them for longer. So these are all important and key pieces to talk about for patients with this new innovative and early therapy. It's exciting because we've never had anything in the past that's been able to have a notable effect on geographic atrophy. It's helping to pave the pathway for many new therapies that are coming down the pipeline, which have a variety of origins, including targeted genetic therapies, cell-based therapies, some using electrical stimulation, others using light therapy. So there's just a great many things coming down the pipeline for dry macular degeneration. But at this time, the options still remain fairly small, but they're growing, which is the really encouraging part of the field and an important thing to remind patients as they're coming into you. I think the most important part beyond just understanding that therapies are out there for them at this time is helping them to know that there are options. Oftentimes, I think the dialogue stops with you have a condition that can't be fixed and you will go blind. It's important to focus on what the patient will be able to do, and that encompasses all the things we've talked about today, starting off with the importance of being able to get and know the resources available to them for low vision therapy, or again, as I like to put it, vision rehab. And then number two, we do have a medication that can slow things down nowadays. It's not an option for everybody. There are parameters that make it more or less valuable for helping somebody achieve some of the goals that they would like to do. But it's an important dialogue to help somebody know the options that they have out there. And then thirdly, don't forget to provide your patients encouragement and hope that there are things coming down the pipeline that are likely within our lifetimes going to be there. It's something that they need to know is out there and to give them confidence and hope that things are being worked on in the future. I hope that this has been a valuable thing for you to take away for your practice and to be able to have a very nice dialogue with your patients with this condition, as I know every single one of us has these types of patients. If you want more, schedule your personalized mini fellowship at Vance Thompson Vision today. Immerse yourself in hands-on learning, gain insights from our experts, and take the next step towards excellence in eye care. Don't forget to visit our website or follow us on our social media for additional resources and updates. Remember, the world of eye care is ever evolving, and so are we. Until next time, this is Dr. Assam.